So it's really amazing how quickly this course goes. Again, I highly, highly recommend you starting on that pediatric assessment project. Everybody needs to choose a diagnosis. It does not have to be on the list that is listed in the modules. There are many other diagnoses, and they're just there as a guide. When you're blank, you don't know, it's you could choose from them. But if not, pick one that, you had, your child had, your sister's kid, your neighbor had, something from your, something somewhere. And they actually makes it a better assignment for you because week 8 is going to get rough, especially with community. There's a lot of stuff that's due, and week 8 does have a lot of stuff that you have to hand in. There is an 80 some odd questions pediatric assignment exam. So that in itself takes you time with the NCLEX questions and the pediatric assessment assignment. And week 9 is an exam. So please don't get yourself bogged down. Okay. So this week 6, you do have one CJ Sims and you have your NCLEX questions that are due. We are having exam next week. It'll be on chapters 4, 5, and 6. So the stuff that I'm covering today will be on there. And the reviews start this week. So I have posted in your announcement those reviews. I'm doing mine on Valentine's Day at 4 o'clock. So that's Wednesday at 4 o'clock. If you want to do mine, know that I always, all the reviews are posted. So you never are without what you need. And I do post the Kahoots, I post the study guide, I post all the recordings in one place to keep you organized, okay? So any questions? All right, let's go ahead and start with this week. What are we doing this week? We are going over the child with hematologic, immunologic dysfunction, and we're going to go into some cancer. We know that in cerebral, we're going to have even more cancers, but right now we're going to go over, it's actually the lymph system type things. All right, so chapter 43. Now, immunologic dysfunction, when parents start to want to investigate either the kid's getting really sick all the time or they're looking pale, no energy, right? Because in all the anemias, whichever type, you don't have red blood cells to carry around oxygen to the body. And when you don't have that, the body's not getting what it needs to breathe. Therefore, there is no energy. Also, the other thing could be bleeding, petechiae, ecchymosis areas, a cut that doesn't stop bleeding. All of these things will bring a parent in. And we know the one thing that can look at all of that is a simple old complete blood count, a CBC. Now, the most common of all hematologic disorders is anemia. And if you want to, narrow it down more, it's iron deficient anemia. So again, one of the things that you need to be aware of as a nurse is this is a child who's going to have decreased energy or feeding related to the lack of red blood cells, and these kids, they're tire out. They're not going to finish eating, and they have absolutely no energy to move. So sometimes red blood cells, there you have enough, and sometimes you don't have enough. It could be just different shapes. I'm going to talk about some sickles, right? Sickle cell disease, and then there's some what I call rectangle cells, and then we're going to be looking at all of those different things. Now, red blood cells can be decreased in the body due to either a decreased red blood cell production or blood loss, right? Bleeding. And then an increased red blood cell destruction. When you talk about that, that's the cells, they just don't last long and they're killed off. So when we talk about that decreased red blood cell production, this is your iron deficient anemia. You also see B12 type thing. One of the things I've just learned, I'm always learning something. B12 deficiency, you can tell by looking at their mouth, at their tongue. It looks beefy red. That's a B12 deficiency, something I've just learned. The increased red blood cell loss, that again is your nosebleeds. That's hemophilia. But it's also something called ITP. We're going to go into that. Idiopathic thrombocytopenia purpura. Say that 3 times quick. And that's just the platelets are low. P is platelets, low platelets. And then the increased red blood cell production, as in sickle cell or as in your thalassemias. Now, there is some things that are due to types of uh, inability to, for instance, glucose, and it's that G6PD. These children, if you put sugar in them, it tends to make their red blood cells burst. I learned that through a mother who we had to get a non-sugared Motrin, ibuprofen for that child because of this disease. I've only seen one. The mother taught me. So anemia, what do you see? Well, one of the things with anemia that you can look at a child, you look at an adult and they look pale. You look at their gums and they're pale. And you're like, okay, well, you're going to see an elevated heart rate, right? Because the body's really trying to get oxygen around, but there's no red blood cells. But then you listen to the heart and you hear it just swirls because all of these cells are banging off of each other. So you hear quite a murmur. Now, because the heart's not beating, the way it should, and because it's overworking, elevated heart rate, trying really hard to get whatever's around, you may go into cardiac failure. So anemia is serious. It's something that needs to be looked at. When we think about children, remember nutrition, 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 right? Oxygen and iron that's in the red blood cell is the food for their body. So if they don't have iron and oxygen, you're going to see a child not as big as they should. Makes sense, doesn't it? So what do we do? How do we diagnose this? Well, I said, first of all, it's that history, that physical, that's looking at the child, they're pale, or you can see them, huffing and puffing, elevated heart rates, seeing those murmurs, all of that. But it's mostly the child is sleeping all the time, has no energy, tires out while feeding, doesn't finish a bottle, all of those things you'll see. So we will do a CBC minimum on these children. Now, sometimes the hemoglobin hematocrit are so low, we do have to give a blood transfusion. I see a lot of sickle cell diseases where they come in and their hemoglobin hematocrit are 5 and 6 hemoglobin, very, very low. And that's dangerous. So we do give blood transfusions. So the minimum we'll do is at least put a little volume in there to get the blood flowing around. We'll put oxygen on. Now, that's controversial because you only have a certain amount of cells. So you can give them oxygen, but does it really get more oxygen to the cells? But we do it because it seems, what we should. And then, of course, rest. Don't overtax these children. Let them rest. These should not be out walking around, ambulating in the hallways. These children, these adults are not going to feel good. So how do we do this assessment? Well, the age of the child, of course, is going to make a difference on how we treat them, but that racial ethnic background, sickle cell, African Americans, thalassemia from the Mediterranean Sea area. So it will give us some little hints. And, taking that history, when did it start? What are you doing? What happens when you're, walking or exercising? All of those things. But let's rule out a GI bleed. It's not necessarily anemia, right? So always let's do a stool for occult blood. Now, children are going to be getting stuck with a needle. They are going to maybe get an IV, maybe get blood, but we're going to be doing lab work. So again, get on that child's developmental level. Try to be as less traumatic about it. I know that in the children's hospital where I worked for many, many years, we would numb the area. So even an IV or a venipuncture, they felt the touch, but they didn't feel the pinch of the needle. They didn't feel that pain. Because you have a kid who's already anemic, right? And then you get them upset, screaming and yelling. What are you doing? You're overtaxing them. That's part of it. And always with anemia, we don't want them to have any complications. Now, iron deficient anemia is when you don't have enough iron in your diet. Now, in infants, we give breast milk and we give vitamin D drops for that child. In the child who's drinking formula, it is iron fortified formula because we want to give them that iron. When they turn 6 months old and we introduce cereals, they're all iron fortified cereals. Again, that's to keep that iron up. Think about the infant. They get mommy's blood. Mommy's blood eventually dies. Their body does not start making cells till after 3 months, so they can't catch up. So they're anemic already. So we really do not want to put the dietary on them too, where they're not receiving iron, because that's a double whammy. They don't have the cells, they're not having the iron. Now, milk babies are when years ago we just gave them whole milk, cow's milk. They're not getting the iron in there that they need. Yeah. Now, what would you do with these children that are iron deficient anemia? Well, of course, if we can change the diet, an older child, we can sneak things in there. They've got these really great fruit juices that have vegetables in them today, right? Let's sneak it in them. The kids don't know because don't tell them. And then it's the iron supplementation. You remember, if we're giving iron to a child or your adult, it's better to take it with orange juice because iron must be metabolized in the stomach to break it down. And then you put orange juice, it's more acid, it helps, okay? Also, with children, the liquid will stain their teeth. Make sure they drink it through a straw. You learned that in pharmacology, but just remember that again. And the other way to give it is iron dextran. It's the IMZ track, iron injections. Those can help too. So depending on the child, et cetera, the doctor will order what they need. Now, sickle cell anemia, there is traits, which means you don't have a disease, but you can pass it on. Okay. We know it's the African Americans, Native Africans are all, there's the carriers are there. And if both parents have a trait, 25% of those children have a chance of getting the disease. Now, what is sickle cell? You know, it's a very simple disease to understand when you think about it this way. You have all the hoses in the body are all your vessels. And those hoses bifurcate to go to little places and literal places, right? Where they bifurcate, a sickle cell can come and occlude it. And then blood can't get lower, right? And what happens? The blood builds up on top of it. It causes a lot of swelling, a lot of pain, because now all that swelling is hitting all the nerves in the area, and it's if we don't take care of it, you're going to have local depth of the tissue below that sickle area. Know that when you have a headache in sickle cell, you're going to do a neuro check, right? Because it could be now something to do with the brain not getting what they need, and now you're thinking about a stroke. So if we have all of this sickle cell going on, usually it's because your vessels are a little bit smaller. When would your vessels be smaller in your body? It's when you're not hydrated, right? Children get up, go out, they forget to drink. They're always running around, they're always sweating, right? These are the children, and what we need to teach them a lot is to make sure that they put fluid in them. When you have a fever, remember you burn more of your fluid on your body, right? You become dehydrated quicker. So again, you got the sickle area. The vessels are smaller. Let's dilate it. Let's put heat on it. Let's give them fluids, and it will open up that vessel and then the blood can flow. And the quicker we get that done, the better it is for the child. It is a very painful disease. These children come in, they're crying. It could be their hands, elbow, knee, chest. As I said, it could be head. And again, if it's head, you better make sure that you do your neuro checks because they could be having a stroke in front of you. So, priority treatment, fluids. Now, doesn't mean I don't have pain medicine in the other hand, because I do. But your priority is to dilate those vessels. So I'm going to have a heat pack. I'm going to start an IV, and I'm going to be given that morphine is usually given. And then after a while, they usually get this sensitivity. So then they're on the hydromorphone or the Dilaudid for pain because this really hurts. So these children, those cells burst quick. There's not a lot of them. They're in a crisis. Um, these children are immunosuppressed. They're taught if they ever get a fever that they need to get emergency treatment because their body can't handle it. They need antibiotics. So one of the things about any immunosuppressed child, one of the things is they say 100.5 or higher, get them to medical treatment, call the doctor, let them know. Many times they'll call in a prescription for antibiotics, and depending on severity of pain, etc., of course, go to the ER, let's get you treated. So we rest them because their hemoglobin and hematocrits are low. As I said, they're usually down. If I see a hemoglobin of 7 on a sickle cell in crisis, I used to be happy. I mean, and it's 7, it should be 10, 12, right? So it is quite low and they have no energy. So let them rest. We are going to get that hydration, dilate the vessels, put that heat on. It's going to dilate them more, and we're going to give them pain medicine. We will look at electrolytes, making sure they have what they need. There's usually a lower potassium. And then antibiotics, absolutely. They'll be given some sort of IV antibiotics. Even if they go home later, they need a dose of IV antibiotics. Now, they put these children on prophylactic, PenVK, penicillin, and they start about 2 months up to about 5 years old. Because remember, their immune system isn't built yet. So they're trying to prevent any big infections from occurring. So they're prophylactic. Another thing we do is we're always going to be monitoring that retic count, that reticulocyte count. Is the body making the cells that it should? And again, that blood transfusion is to get oxygen around because you're given hemoglobins of 14 into this child. And now the body's going, ooh, I got my oxygen. I'm getting my iron. I'm feeling better, right? Now, there is no cure. They do some bone marrow transplants on those children who are having frequent type of crises, but there is no cure. As I said, they're immunocompromised. They are really going to be getting sick constantly, and it is the bacterial infection is the leading cause of death. These children, these parents are taught as soon as they get a fever, they need to get those antibiotics in because they have no immune system to speak of to fight it, and they can go into septic shock really quick. So early intervention, give that penicillin, that prophylactic as they're ordered. Remember that stroke can be a problem. Chest could act like a pulmonary embolus, right? So all of these things are serious. Now, these children, although they're very brittle in many ways, kids need to be kids. So if they want to get up and go out and play with their kids, et cetera, make sure they know to hydrate. Hydrate before, during, and after. If they're going out in the cold, make sure that they are dressed properly to keep their body warm. Because if it gets cold, those vessels are going to constrict and you're going to have a crisis, right? Now, thalassemia is very similar to your sickle cell in many ways. So, sickle cell, the cells go and they die quickly. Thalassemia, I call them the rectangle cells. And what happens is they burst. There's a very short life. And when they burst, what's inside that red blood cell? iron and oxygen. So these children are going to be more apt for too much iron in the blood because of those cells bursting. It is genetics again, it's just like sickle cell, but they say it's descendants of people from the Mediterranean Sea. Now, there are four types of thalassemia. You do not need to know the names. Usually, when they do thalassemia and they're testing on it, they're talking about the major, the Cooley's anemia, thalassemia that their cells are bursting like crazy. Their body is not producing the cells that they need. So these children that grow to be some adults need a bunch of blood transfusions. It could be weekly, depending on the child. So one of the things is you're born with mommy's blood. So initially, you don't see that a child is having thalassemia, okay, because the cells look okay. But about 6 weeks in age, their cells change, and that's when they see it. And what we'll usually see is a child that, of course, what's in those red blood cells? Oxygen and iron. These children can't breathe because they can't suck, swallow, and breathe. They can't feed. They're not gaining weight, and it's usually that failure to gain weight that brings the attention to them. And like my kid just tires out, doesn't want to eat, always falling asleep on my breast or while feeding him. These again are clues. Now, as I said, this disease is the red blood cells bursting, and the iron's going to go out into the body. And when it goes out into the body, it becomes to the point where it's dangerous. So they need to address that iron. And they do usually just give oral medications called iron chelation drugs, but sometimes they're going to have to do this apheresis, it's called. Now, we have dialysis, which takes urine off, but we have another machine that can just take off the iron. It's called an apheresis machine. You can take off whatever body part you want. And again, it's run at the bedside, just like a dialysis, and they pull it off. But usually, that would be in a severe case. But after that, they can do the iron chelation drugs. Now, thalassemia, because it's you need to have on that major, that Cooley's anemia, we're going to be needing transfusions regularly. So children need to come in when they're supposed to get their transfusion because they get the blood and their hemoglobins are high, and then it dies, right? And now your heart starts working again. And then you get that blood and your heart slows down. And then the blood cells die. So you can see your heart's doing a yo-yo here. A lot of times they go into heart failure because of this. Another one of those. These children are going to be in and out of outpatient centers and blood transfusions, et cetera, et cetera. So it really is a lot of stress on them. So as nurses, making sure that you see that the parents and the child have good open relationships, and then showing them maybe some uh, resources in the community that they can talk about what's going on, whether other children who have thalassemia, et cetera. Those things are important, and sometimes we forget about them. And then remember, all of these blood transfusions, there's going to be some complications. Remember, you have a blood transfusion, you see something that's not right, elevated heart rate, or all of a sudden you see a temperature or whatever, turn it off. Number one, turn it off, right? Now, these children can become adults and they can live as long as they are getting their transfusion, their chelation therapy. Sometimes they'll take the spleen out. And the reason why they take the spleen out is because the spleen is just producing cells that are just bursting in the body and creating all this iron to be, distributed a lot of times, because again, they're immunosuppressed. they have post-splenectomy sepsis. And then, of course, they go into just total overwhelming sepsis. It becomes multi-organ failure. Maybe again, this is something that a bone marrow transplant can cure. But again, we really don't know. Now, aplastic anemia. Usually we talk about aplastic. It's a pancocytopenia. It's all formed elements of the blood aren't working. That means your hemoglobin, your hematocrit, so you're anemic. Leukopenia, your white blood cells are low, so you're apt for infections, right? And then thrombocytopenia, you have no platelets, so you're bleeding. So this is of all of them, something that affects everything. It's not just red blood cells bursting, it is a lot more. We treat this actually like a leukemia, and we give them immunosuppressant therapy and we give bone marrow transplants. And, hopefully we can get it under control. Again, as a nurse, we're going to be washing our hands, putting a mask on if we have a cough. We're going to be protecting them as much as we can, not overworking them, and looking for all the signs, of the lack of platelets, bleeding, etc. Now, defects in hemostasis. When you think of bleeding too much, you think hemophilia, right? That's one. There's factor 8, there's factor 9. It comes from mommy. It's an X-linked recessive trait, okay? So mommy's the one who passes it on. There is A, B, and von Willebrand's, and they're basically blood clots in the body. And there's certain things in the body that helps it clot properly. It could be a factor 8 that helps, or 9, or von Willebrand's. All of them are needed, but there's a lack of something. How would you know? Now, sometimes you know at birth, sometimes you don't. But what you would see is a child who's, cuts and just starts bleeding, 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 bleeding. One of the concerns with hemophilia is the child who's active, because you want them to be children, right? They fall down, they hit their knee, and it starts bleeding a little, bruising. Well, that little bruising becomes that whole joint capsule filled with blood, hemoarthrosis. Remember that blood in those, joint capsules causes a lot of crippling later on in life, and it's what we want to prevent, okay? And then we have, of course, you're going to have bruising. So what I said comes from mom, and then we're going to be doing this labs on these children. We're going to be looking at bleeding coagulopathy labs initially. These factor 8, 9, or von Willebrand's, you don't get those results right away. So we have to base our initial on that PTT, right? We can do a parathyroid and fibrinogen. Those can be done. They have to do with bleeding. Now, what do you see with hemophilia? Well, it's the PTT that we will see very elevated. We don't know yet that there's that low factors yet, though those have been sent. But you'll see normal platelet counts and the others, and it sort of gives you that clue. So PTT's prolonged. I mean, it should be what, 40, and it could be 400. So in the case, the child's fallen down at home, and it's a long-term, child with hemophilia. Well, they've fallen down. We see the bruising, and of course, we're going to do that rice. We're going to rest, ice, contain, elevate. What we would do for a fracture or a sprain to try to decrease that swelling. I mean, put ice on it. But we might have at home those missing clotting factors. I've actually seen a little boy. He did come into the ER only because they couldn't get a hold of the hematologist. He literally had fallen down. His knee was bruising. The father was concerned, and they brought their factor 8 in and their equipment in with them. And our doctor said, yes, he should get it. Well, I was his nurse. I actually had a new nurse orientee with me. And I said, let's just watch the father. Now, I'm a little OCD with my technique. I make sure everything's done the best I can do, especially with children, especially if a parent's and they're watching you too, right? Well, anyway, that father was amazing. So he washed his hands, he took the powdered factor 8, mixed it with the liquid, pulled it in a syringe, put it in this tubing, and it's in a butterfly, believe it or not. And what he did is him and the child figured out what vein they were going to use. And that child actually put his finger on the butterfly to hold it in place while the father pushed it in slowly. And I was like, that was amazing. I could see such a great communication between father and the son. And even my orientee was like, wow, that was wonderful. I couldn't have done it like that. I said, well, I think his father's done this more than one time before because it was really refreshing to see. Sometimes the hemophilia is not as severe, so they might give this desmopressin, okay? Might do it. Or sometimes they'll do it the amycaproic acid. But usually it's a factor, and usually they go to the clotting factors. So, like I said, with hemophilia, it is you fall down, you see their bruising, ankle, knee, toe, finger, whatever. Make sure they rest, ice, elevate, and they compress it. But we added one more thing, P. What about a newly diagnosed toddler with hemophilia? That child does what? Bumps in, hits his head on everything. The coffee table could have a sharp point. They could cut themselves. Make sure that the parents either pad the furniture or replace it with something, right? Because we want to make sure there's no areas where these children can just rub against and cause a bleeding. And then, of course, that could be a problem. And as I said, with hemophilia, we want to prevent that crippling effects, those hemarthrosis, those joint sacs getting full, because it does. It's caustic and it will, ruin those joints and they'll end up in wheelchairs. We don't want that. So as long as we have done our job, and that child and that parent knows about, giving the factor, about rice and price, we can get these kids living a pretty near normal life. They are working on a gene therapy for it. We're close, but still a little bit more work. Now, immune thrombocytopenia purpura, ITP. P for platelets, which means your platelets are low. Platelets are part of your bleeding coagulopathy, right? No platelets, you're going to bleed. So, what do you see? Well, I've seen children, usually they've had a recent upper respiratory, a viral type of infection. And then all of a sudden, the legs are full of that purple looking purpura on that arm. You'll see it on the legs, or you might see bruising. And the mother's like, this kid doesn't go out and do anything. They sit on their iPad all day. I don't know how they're bruising themselves because there's no reason. And that is the clue. Okay, what are we going to do? Well, we're going to do that CBC and find platelets, and it's usually below 20,000. So initially, we are just doing supportive, which is we're going to be watching for bleeding. Usually, these children are brought into the hospital. They're given that IVIG and they're given anti D antibody. It is from a viral thing that has affected the body and the platelets, okay? So, as a patient in the hospital, we're not going to do any sticks by IV or IM if at all possible, right? Because every time you stick them, these children, their platelets are low, they're going to bleed. We're also going to be watching for bleeding, gums, stool, urine, anywhere. And if they're in the hospital, probably doing a CBC, checking out what is their platelet counts? Is it recovering, with the support of the IVIG and anti-D? Sometimes, they put these kids on steroids. So again, when you're doing thrombocytopenia, you're always watching for bleeding. That is the big caution. Epistaxis sometimes is what brings these children in with ITP also, or von Willebrand's, or even hemophilia. Now, it could be leukemia. Leukemia, you're going to see low white counts, but low platelets and low blood counts too. So these are things we'll be looking for. CBC. Now, when you have a nosebleed, what do we do? Well, number one, you need to calm the kid down. Don't kids feel when they get cut, they're going to die, they're going to bleed out, and I'm going to die? I mean, that's your toddlers into your school age. They don't like blood. Remember, it's the age of the band-aids, etc. So they are freaking out, literally. So we need to calm them, distract them, do whatever we need to do. It decreases the blood pressure, decreases the heart rate, decreases the amount of bleeding, and we can maybe clot off what's ever going on in that nose. Pinch it between your thumb and your forefinger. Lean them forward because we don't want back because they'll swallow blood. Lean them forward, it will come out. All right. So less aspiration on it. And they say if after 10 minutes it doesn't stop, they need to get to treatment because something else is going on. HIV/AIDS, in this case here, we're talking about how do they get it? A lot of times it comes from mommy in pregnancy and it gives them the infant it. They have been working on this heart treatment, that highly active antiretroviral therapy, and we usually start that at 22 weeks gestation, and then giving it to the child even after birth. Now, remember, infants are born with a very minimal immune system. And if they've gotten it from mom's immune system is low. So we need to give those antivirals to boost and improve that newborn's type of immune system. So prognosis today is better than ever. Now, I worked as a clinical instructor at a extended pediatric daycare, an amazing place. And they had triplets there. Now, from a mother with HIV. One had HIV AIDS, one had HIV, and one had nothing. And I have seen in my career infants born with HIV and they auto convert by 1 year with proper treatment. So HIV isn't that quote death sentence that it was when we first started learning about it in the 80s. There's just so much more that we do and can take care of. One of the big respiratory things is always that pneumocystic cardiac pneumonia. I mean, again, it's very, very dangerous with those young infants. They're immunosuppressed. They have no immune system. So getting on those antivirals quickly is exactly what we need. So again, with HIV, we have other concerns. You know, another parent hears that that baby has HIV in the same room. Let's say it's an open room, you know, and they're, oh, I want my kid out of here. That is going to catch it. So the confidentiality, very, very important. HIPAA, absolutely here. Immunologic disorders, and what do we do and how we take care of them? Well, we give blood transfusions, remember, or platelets or packed red blood cells, any type of blood we can give. Again, if something happens immediately, any sort of reaction, you stop the infusion is number one. As I said, that apheresis, like we can take off certain things. We can, like the iron. So apheresis is sometimes done. And then we do bone marrow aspirations, especially with some sort of hematologic issue. We want to look at the cells. What do they look like? Is there anything else going on? And if you've ever seen or been there when they do this bone marrow, when they take that blue thing and put it into a bone, you can hear it go as they get lower and get into the bone marrow. It hurts. Now, today, we numb the outside. We put numbing lidocaine within deep into the tissue, but there's still a little pain. And with children, whatever the procedure is, if it's going to hurt a little bit, let them know, right? Just like the chest tubes coming out. Let them know. But let them know that we'll do everything to make it as little as possible. So when both parents have sickle cell, what's the chance of the child to have it?
100%. Do we put it in the chat or do we say it? I'm
No,
sorry.
you just say it out loud.
100% because 1 + 1 = 2. So if both have it, the kid will definitely have it.
And if the mother has, the father have traits, how many chances that the child will get the disease?
Say that question again.
If
Yeah,
both parents have sickle cell trait, what is the chance that each of their children will have sickle cell anemia?
100%,
No,
right? No.
it's 25%. The trait is different than the disease. Okay?
Yeah, okay. Yeah, I got
Okay.
it. Okay. Because they carry 50%, they'll pass off the 25 to each
Right.
child. Okay.
Right. All right, some neoplastic disorders. We're going to be talking leukemia and lymphomas. Again, it's related to the blood and the lymph glands, immunological systems. Now, leukemia is a malignant disease which affects many different things in children. It's very common, believe it or not, and you always see it in children that 2 to 5 years old. And it's very difficult. More frequent in boys than girls, but today survivability is so much better than it was even 20 years ago. Leukemia is the unrestricted proliferation of immature white blood cells in a blood forming tissue, which means you really don't have a white cell count. They're just immature and they're not working. The liver and the spleen will be affected with them, and it's a cancer, so we have to really treat it. So, my next door neighbor at age 14, now it's older, but she started to feel tired. She looked pale. She had knee pain and she was getting these bruisings that she's never had before. She went into the ER and they drew a CBC and they looked at a blood smear and her white count on the first draw was 0.1. White count is 7, 10. I mean, she had like 1,000, 100 white blood cells in her body. So she was admitted, and they took care of her. Now, those are the types of things and signs and symptoms that you will see. So when they did that blood smear, they could see those white cells weren't good, and then hemoglobin hematocrit were low, platelets were low, and of course there was absolutely no immune system, no white cells. So what do we do? How do we treat it? What we do is what we call the chemotherapy. And the first stage is literally hitting this child with how many types of chemo to completely knock out all the cancer in the body. Okay? 4 to 6 weeks, and the goal is actually remission. But there are some sneaky cells that still stay in the body. So they go and they put it in the central nervous system. They also put them on longer therapy to make sure if there's anything in there that we can get rid of it and to preserve that remission of the cancer. Okay? So induction goal is that remission because I mean, it could be 3, 4 different types of chemo, what depending on what sort of cancer it is. Now, sometimes they need to do a hematopoietic stem cell transplant, and there's different types. Now, today you're given that opportunity to take the infant's blood, umbilical cord blood, and save it, but it's expensive. So many people don't. That's actually the best of all of the type of cells that they can just replace it into that body, and it can, change the leukemia. It's called autologous. Now, how do I remember autologous allogenic? So autologous is automatically mine is the best. I want to use mine. Allogenic is all the other people. And it doesn't have to be like a blood transfusion. It's mismatch doesn't matter. So automatically mine is the best, and all allogenic is all the other people. Now, it's still a transplant, right? So you still worry about graft versus host. The problem with stem cell transplant, they infuse it like a blood transfusion. It goes in your body, so it could be anywhere in the body that can be this, conflict, graft versus host, and it can do severe organ damage. Again, chemo and everything we need to do for leukemia, they're getting bloods, they're getting platelets, they're getting all sorts of things, because chemotherapy doesn't just kill the bad cells, it kills the good ones too. So they are unbelievably in and out of this hospital, usually an outpatient infusion center within hospitals. And they're getting maybe an IV antibiotic, or maybe getting one of their doses of chemo, or getting blood. Or so it is needed that we really tell these children what we're doing, why we're doing, and getting them aware. And it is painful. So making sure that we evaluate the pain in these children. Now, because there is no immune system, our biggest thing, what is it? Well, infection. Because there are no cells, I mean, even the red blood cells are depleted. We need to look out for, and platelets also are depleted. We need to look out for bleeding, so watch for bleeding, and then, of course, anemia. If it's at a low stage, remember these kids are tired out easy. Don't overtax them. And as nurses, be careful when we're administering chemotherapy drugs, because it can be absorbed in through the skin. One of the biggest areas in nursing that's giving big bonuses for sign on and even traveling is oncology nurses in the pediatric area. You get that experience. It's sign on for 2 years and there's $20,000 bonuses. I mean, it's quite insane the amount of money that can be made. Now, yes, you're working with children and many of them do die. And that's the hardest part. But I tell you, working in the areas where children don't all make it, it's not that they lived or died. It is, what did you do for that child while they were in your care? Did you make it a better day for the family and the children? I've got many parents who those children died, but I gave them so much while they were alive. 20 years later, they still reach out, send me texts, send me messages on Facebook because of what did you do when they were alive? And yes, I cried with many a parent, and there's nothing wrong with that because it shows that you do have feelings too. So always remember that when you're working with areas like, I don't think I could do that. Well, do you like taking care of people, make them feel good? Do you like to be a teacher? Okay. So leukemia, the biggest thing is, what was their white count at first? Now, Mig Young is the name of the girl. She was a Korean family. Mig Young had a white count of 0.1. Sometimes there's 0.01. So depending on what that number was, also will make a difference on outcomes. How old were they? What was the cell? Now you have ALL, leukocytic leukemia, and AML, myeloid leukemia. AML is harder to diagnose. It's harder to treat. It's takes longer, more intensive. So ALL, if you gotta have one, is the better one if there is one. Also, boy or girl makes a difference. And then what is your blood type? Are you a rare blood type? Because that's going to probably at times they won't have the blood or the platelets that they need, right? So again, you're A positive, you're good. But some of these very rare ones will make a difference in treatment. So let's go over some cancers. So in cancer, there's a couple things we can do. If it's a tumor, it's something we can take out. We can do chemo. Radiation will shrink it, and we can also do surgery. Um, these children with cancer, and they're getting all sorts of chemotherapy and blood and stuff, they always put in a permanent port of some sort. Usually it's underneath the skin, so it doesn't hang out and it doesn't get ripped out type thing. And that prevents a lot of the stick needles, right? Now, what do we see again with, cancers? Well, basically what I've said before, pain, fever, ecchymosis, petechiae, bleeding, lethargy, and, looking anemic. These are all what I said with leukemia. Same things. And then remember, vision changes can be something going on in the head. Now, one of the things that we need to be concerned about and always be aware of with any patient is neutrophil counts. So, neutrophil counts measure how the body can take care of infections, basically. Now, usually it's 1,200, 2,200. The number is big. Sometimes we'll see, and it doesn't matter if the kid has cancer or not, just a kid that's, doesn't have an immune system, and there's many reasons for that. But you see a low neutrophil count, this is the child that's your priority if they have a fever, because they're going to go into septic shock immediately because there's nothing to fight it. So that one needs immediate treatment and IV antibiotics started as quick as we can. So understanding that, knowing that as a nurse, you're going in to check your patients for the day, make sure you check that. Always, if we're looking for infections, get the specimens, do it properly. That broad spectrum antibiotic therapy, sometimes they put on two, sometimes they just put one big strong one on. It all depends on physicians. And again, washing hands, always number one priority with neutropenia. Wash your hands. Hemorrhage is a big thing that can go on. Platelets are low. So making sure that if this child is getting infusions, or going through this sort of any cancer, that their hemoglobin, hematocrits, platelets are low, be careful with them outside. They shouldn't be riding a bike, falling down, skateboards, skates, contact sports, because they're just going to hemorrhage more. And then anemia, because of the amount of chemotherapy that's given in that induction, it does get rid of your good cells too. So be aware of it and give them plenty rest periods and limit their tolerance to physical activity, right? One of the things about chemo, and you always think of, oh, it makes you nauseous and make you vomit, right? Well, today they are, and they didn't do it when I first started nursing, believe it or not. You had to vomit before you could get an antiemetic. Today, if you know they're going to be nauseous, we're going to pre-medicate them so they don't vomit, right? So that's another change that you've seen. Also, they're finding out with cancers that those synthetic cannabinoids work. I've seen a couple documentaries on it, and just little drops of oil or something, and they've prevented seizures, they've helped with nausea, vomiting, and they had a better life during this period. That's a personal decision. And again, anything like that should be with your physician taking care of the cancer also, so they know what this child is getting, overall, vitamins or anything. Their nutrition, they're not going to want to eat as much. Many times they've got really bad sores in their mouth, so they don't want to eat. So again, giving them foods that they can get down that doesn't burn inside their mouths. It's easy to chew. And it's high protein, high calorie, and full fat. That means load them up with anything high calorie and fat because they're not going to be eating as much, and nutrition is so important. How do we know if they're getting proper nutrition? Any child is height and weight. That's why we always do height and weight. Another reason that we do it. And then there's also monitoring those albumins. I mean, remember, albumin has to do with wound and healing, right? It aids in wound healing. As I said, that mucosal ulcerations can happen. That's why easy foods. And then also anything about the brain, you got to be concerned, as in children who aren't eating, they're on pain medicine because they hurt. They can also, and they've got low blood counts, low platelets, low hemoglobin, hematocrits. These children, if we let them get constipated and bear down, can stroke. So we're going to prevent that. Number one, we're going to be watching their stools, and documenting them and giving stool softeners. And high fiber in their diet, you may or may not get it in there because they really, really don't want to eat. Also, remember if they are not up and walking, to keep preventing foot drops and, keeping the skin in good condition. And, some of these kids, you're going to have to turn some side to side, etc. And sometimes, again, anything with pain, especially if it's the jaw, they're not going to want to eat and chew, right? So, again, making sure they are medicated for pain is one of the key things. They can have hemorrhagic cystitis. So again, watch for that blood. It's because of all those blood values, right? And then of course, children, adults, they lose their hair in chemotherapy. I've seen sisters, brothers, aunts, uncles, all different people shave their heads with their children. Whenever I was working with these kids, I used to always have ribbons, the little ribbons in my locker and a little round spool, all different colors. And I would come in and I'd make them their ribbon for the day. I'm like, how many colors are we using today? And I might put one in my hair too. I might send one home to their sister. And you know something? I'm like, you're just so beautiful with your ribbon. So let them focus on a ribbon, not on no hair, because kids are, worried about it. And then they get steroids a lot. So Cushing syndrome. Um, One of the things, and I think even me, when my shirt's tight, I'm pulling it and I'm self-conscious, right? Well, what if they're in their gown and it's tight and it doesn't fit? Always make sure they have fitting clothes. That's a big thing. For procedures, many of the times, like bone marrows, all those things, they are sedated, okay? So they know all about it. As I said, always try to decrease the pain by any topical or even putting the lidocaine deeper into it to make sure they have as little pain as absolutely possible. We can use opioids, right? Sure we can. But remember, acetaminophen and ibuprofens work well too. I mean, we might have to be careful with ibuprofens because of bleeding, platelet aggregations, but most of all, we have that ability to give them a little bit of both. But distract the child. It's an amazing thing. Put on a movie, give them some activity to do. And it could be elevating the head of bed, hot, cold, positioning. So many things we can do to decrease the amount of pain. Now, Hodgkin's and non-Hodgkin's lymphoma, it's always a question on an exam, and there's always people who get it wrong because one is just consolidated and the other one is like all over the place, all right? So, Hodgkin's disease is the lymph node system. So, your lymph nodes, like in your neck, underneath your arms, in your groins, all those lymph nodes get really swollen. Now, this is the difference. Hodgkin's is from the shoulders up, and you get those big neck type of lymph nodes that stick out. They're painless, they don't hurt. But those big nodules bring those kids in because mother thinks, oh my God, look at that thing. They've got an infection. Well, it ends up being Hodgkin's lymphoma. Now, if we let it continue to grow, it will occlude the airway. Therefore, it can cause some problem with breathing, that cough. all right? And it's swelling there and they don't want to eat. And then you'll see fever, anorexia, weight loss, etc. How do we diagnose these things? Well, we do that history, we do some inflammatory factors in the labs, but we do a biopsy. It's right there. We'll put them, of course, under sedation or to the OR, wherever, and we'll just take a little piece and we will see Sternberg Reed cells. And that's telling you it's Hodgkin's lymphoma. We can do radiation, we could do chemo. Either of them work okay. But the problem with chemo radiation, they say that this child might be at risk to be infertile as they grow up. So it's one of those side effects of it. Remember, radiation, if they're doing it, they're targeting an area, never ever wash them. Those little, usually they're blue or purplish marks. Don't ever wash them off because they need to go where to go, the same place the next time. Now, non-Hodgkins, you don't see them. They're diffuse. They're everywhere. So Hodgkins, neck up, and you see painless, big lymph nodes. Non-Hodgkins, it's everywhere. The word is diffuse. It is, again, we'll try to get a biopsy, find out where it's at. And again, we'll do the chemo, we'll do radiation. And you see it's sort of that one because it's everywhere, not just a certain area. It's almost like leukemia, induction, consolidation, maintenance, et cetera, et cetera. And these kids, some of them, the outcomes depends on treatment and how when they get it. Brain tumors, most common solid tumor. So, brain tumors. Usually, you'll see a child who has headaches that will wake them up at night. You'll see a child vomiting, not related to what they're eating. So, there's no sense in trying to figure out where it comes from. It's probably a brain tumor. So with these, a lot of times they'll do radiation first because it's in the brain. They want to shrink it to take out as little of the brain as possible. And of course, they'll do chemo and they'll do surgery. Postoperatively, the kid can look like many things. They might have drains, etc. Make sure you know by physician orders if you can lay them on that side, if it's on a side, or you can't. How elevated the head of the bed can be. Positioning is huge in brain tumors. Another thing is intake output fluid. You don't want to over fluid these children, right? Because it put more pressure in the brain, and we don't want to do that. So being careful with not getting too much fluid in them. And these parents need to know these kids sometimes come back with a wrap around their head and tubes hanging out. Prepare them because it is very scary. Many of these children will need therapies after. It could be they have problems with speech or problems with walking, but all of that will be taken care of when they know exactly what's happened in the surgery. Now, a neuroblastoma, it's very rare, okay? It's usually you find a lump in the abdomen and it gets so big it crosses and takes up the whole abdomen. So it starts on the side and then it goes what we call past midline. And usually it's already in the brain by the time it's diagnosed. So these children don't do very well. We do, of course, all of the things, radiation, we do chemo. These kids, a lot of them, because it's already from the abdomen to the head, outcomes are not the best that we would like to see. Now, bone cancers, osteosarcoma, osteobone sarcoma cancer. This is a child you see a lot in your teenage, the adolescent area. And we say, oh, it's just that growth spurt. It's just aches and pains. And it starts with uncomfortable in the leg. And then it starts limping, and then it gets worse. And then they do an x-ray and they see this fuzz on the side of the femur bone. And because it's a cancer, they're going to see that they're apt to get infections, right? Their white counts are not keeping up with them, cancers. And then, of course, weight loss. They're in pain. They hurt. They're not interested. So, what do we do for this child? As I said, a lot of times they're that, pre-adolescent, that all about body image, right? Can you imagine? They have to take the whole femur bone out. So, they're left with nothing. So, what they've started to do is take the lower leg, and you see that picture on the left with the red and the black? They take the lower leg, turn it around, and put it back into that hip joint area. And why? Well, it's a place for to put the prosthesis. So they'll be able to walk. So they'll be, looking, quote, more normal. We call that salvaging the limb. And these kids, through therapy, do okay, as long as we haven't metastasized anywhere. Wilms tumor, I've seen one. It was during the Haitian earthquake many years ago, back in 2012, I think, 2010, something like that. We went as a hospital, went down to Haiti and offered medical assistance, and they found this little 3-year-old boy. And in his abdomen was like a grapefruit sized hard tumor. And what they did is through some religious organization, got him to the airport. Some group picked him up, had the medical records with him, all in French, I might say, and delivered him to the ER where I'm a triage nurse. And I'm like, so why is he here? I don't know. Do you have records? Oh, they're in French. Okay. I don't know French. So I had to do a good assessment. So I had to get on the level of a child who speaks another language. So I got down, I gave him little stickers, I made him smile. I know a little couple words in French. He giggled. Okay. So then I did vital signs. Everything sounded good. Listened to his heart, his lungs sounded good. I went and touched his abdomen, and in the right lower quadrant, I felt this grapefruit sized tumor. And I went, that's a Wilms tumor. How did I know that? I don't know, because I had never seen one before. I don't even know how I knew the name, but sometimes things just come back to you. So, the problem with these tumors, they're fragile. And once you manipulate them, they can have little pieces break off and it metastasizes. So it's a big thing that we put this little thing sign up at the bedside. Do not palpate abdomen, because it can cause all these little embolus, metastasis to go around. And now you've got, more than just this tumor. They don't even do biopsies of it before surgery. So we'll do radiation, maybe chemo, and then we're going to be doing surgery, take it out. We try to do it as quick as we can to prevent those metastases. And again, please, with these children, do not touch that abdomen. We all want to touch it to see how big it is, but don't do it. Leave it alone. This usually boys, 3 to 5-ish, where I've been reading about, and they need to go through the front to the back to those kidneys. So, and it's a kidney tumor, and we need to be aware post-operatively. We've manipulated the bowels to get to the back where the kidneys are. So monitoring, bowel sounds, bowel function. And also we have a kidney tumor called a Wilms tumor. So we need to watch urinary function. And of course, always, we need to watch for infection. That little boy went back to Haiti and actually wrote the unit where he did most of his recuperation. Somebody wrote a little letter and was telling the nurses, thank you, I found out. Rhabdomyosarcoma is these little things that come out of the eyes, the ears, the nose. And it's again another tumor that we will have to go in. It's called a soft tissue sarcoma and get it removed. A retinoblastoma. This is, you see that eye? It used to be the way you took pictures with the camera. The eyes used to turn white. Well, this is just normally. It looks like what we call them is a cat's eye type of whiteness. You go outside at night, there's a light shining, and you look in the distance, and you might see a cat, a dog, a cow, a bear, or whatever, and you see the eyes shiny. Well, that's what it looks like. Um, and it is severe cancer. It's from the retina. They do that irradiation again. That's that purple mark that you would see. That leave it alone. They do chemo, and then what they do is they have to take the eye out most of the time, and then these children end up with a prosthesis in order to, give them that appearance. I didn't realize it in high school, but there was this boy who used to take his eyeball out and roll it around the desk. Then he put it back in his mouth and stick it in his eye socket. And we were like, of course, he did it to gross out the girls, right? But it was, I think he probably had this, that he had a retinoblastoma. Germ cell tumors. This is those testicular cancers. I had an 18-year-old boy who came in complaining of testicular pain, and his testicle was huge. And when we did a chest X-ray, we found already metastasis everywhere. He said he had just gotten the pain in his testicle. Well, for them to be as large as they were, he probably had been there for a while. And what we found out is 3 months later, he did die because he didn't get to treatment quick enough. So men should be doing testicular exams, just like women do breast exams. Liver tumors, remember we have a couple lobes in the liver, so you take out the lobe and they usually do really well. So cancer survivors, it's better than ever. There's just so many new chemos and new therapies that are out there that we know that children are living longer than ever. So, I mean, some of the things that could happen, yes, could be that they have, sterility, can't have babies when they're older, but, they got through the cancer and they have the ability to live a life. So, I mean, this is that Facebook picture where you're like, wow, you look at a girl or a boy, yeah, a little girl, she's in pink, and say, wow, I can imagine what she's been through to get cancer free, right? Any questions? Who wants a cahoots? Who's going to win? Nicosia, I see you smiling over there. Must be you today. Laura, you going to try today? I know you don't feel well. I could tell. Again, you can use your phones to do that little code up there and go right through, or you can go to www.kahoot.it and add that code 5498929. And if you need to, sit there and listen. I believe there's 50 questions today. So remember this week, get to yourself to one of those reviews. Make sure you're listening to them. It's a lot of information on this exam. We have respiratory, we have cardiac, we have hematology, immune, some cancers in there, and then all those variations of nursing, cognitive uh, diagnoses, and it's just quite a bit shoved into one exam. All right, let's get going. Week 6, halfway through. Which statement best describes a neuroblastoma? Remember, this is the one that starts in the abdomen, right? And gets big, and then it goes to the brain. And it's usually already what? They're already metastasized by the time that we get it. It's very uncommon, very uncommon. Not many have it. That's why I didn't go in it totally in depth. It's just showing you sometimes how quick cancer can go on these kids. What is priority treatment for a newborn of an HIV positive mom? Well, newborns are born, mom is HIV, and as I said, there is ability to convert these children to not have HIV. How do we do that? HIV is all about the immune system, right? So we need to boost that infant's immune system. That's how we do it. HIV is a virus. Antibiotics is not going to do anything. What are symptoms of sickle cell anemia? So if anything, is swelling and then pain. And then if we keep going on, of course, it's not going to have that growth that they do need. So remember, if it's vision problems, anything in the head, always worry about neuros. Something's going on in the head. So sickle cell anemia affects which cells in the body? White blood cells, red blood cells, nerve cells, gland cells, which cells? It is red blood cells. Remember, it affects that cell that carries oxygen and iron around, which is red blood cells. What kind of a hematocrit would someone with sickle cell have and why? What did I tell you the normal hematocrit is on those children coming in sickle cell crisis? It's going to be low. These cells die quicker. That's the big thing. Thalassemia, sickle cell, those cells die. The thalassemia explode, putting iron and oxygen in, where it's not used. So they die quicker. They're low. What is the treatment for sickle cell anemia? Number one priority is IV fluids. One of the things they're saying about sickle cell anemia is not to get on airplanes because the pressure constricts their vessels. So airplanes should be used infrequently. What is the reason children with iron deficiency anemia are easily tired? Iron deficient anemia. Why are they tired? What does anemia mean? Well, they don't have iron and oxygen going to the body in the red blood cells. They're decreased. So you don't have red blood cells, body's not getting iron, body's not getting oxygen, and they're tired. Aplastic anemia includes a depression of which blood cells? I look at aplastic anemia and I think A is without stuff that causes anemia. And then I'm saying they're without a lot more. They red blood cells, absolutely, but it's also white blood cells. So they're neutropenic, and then their platelets are low. So it's thrombocytopenia. They bleed, they get infections, they're tired because they don't have their red blood cells either. It's a triple whammy. Most common type of anemia is and that's iron deficient anemia. Thank goodness it's not sickle cell or aplastic anemia. Iron deficient, we can give them nutrition or give them supplements. What causes pernicious anemia? What's pernicious? The intrinsic factor, right? And where is it located? It's in the stomach. And what does it cause? It's B12 deficiency. Remember, you can look at these children, adults, look at their tongue, and it looks like a big, red, beefy looking tongue. And that's one of the signs and symptoms. Let me see your tongue. You can rule it out right there. Which symptom is the single most common symptom of anemia? Anemia. What is it? Lack of blood. Lack of red blood cells. You don't have red blood cells, you don't have iron, you don't have oxygen. What are you going to see? That's how you need to break those questions down. And it's fatigue. They have no energy. And in younger infants, they're not going to have the ability to eat, and they're going to have all of those problems with no weight gain. Good. When teaching parents about beta thalassemia, the nurse informs the child is at risk for what? What is that thalassemia, that Cooley's anemia? It is a shortened cell life. Those red blood cells, I call them the rectangular ones, burst. What's inside a red blood cell? Iron and oxygen. So it's chronic hypoxia and iron overload. That's how you have to think that question. Thrombocytopenia has nothing to do with thalassemia. What lab values do you see with hemophilia? Well, we know hemophiliacs bleed, right? So which one of these show bleeding? Simply. So low platelets is your immune thrombocytopenia purpura, okay? That's not hemophilia. Hemophilia, your PTT is way prolonged. And then whatever factor you don't have are, of course going to be decreased. But your PT and platelets are normal. And that's the difference there that you can see. Why are they bleeding? Is it the ITP platelets or is it hemophilia? You can tell right there by the platelets. Priority treatment for a child with a sickle cell crisis is what? Coming in there hurting. Their knee is swollen, hot, it's painful. What are you going to do? And you could do all of these. What's priority? IV fluids. So you're going to treat what you see, not the cause. The cause is the vessels are small, the sickle cells can't get through. IV fluid is priority. Dilate those vessels. So now the cells can go through and then the pain will go down. Now, I'm not saying you don't have heat in one hand and the pain medicine next, but priority. fluids. Make sense now? What is immune thrombocytopenia purpura? ITP. What is P all about? And that's how I remember this one. It's all about platelets, not enough. And this is the one you might see a nosebleed. This is one you might see ecchymosis or, a petechial rash on them. Platelet counts are down, and this child you're going to have bleeding precautions on. Thrombocytopenia can cause the following symptoms. So that is the petechial hemorrhage, ecchymosis, epistaxis. A lot of times it's the bruising that brings them in, or the nosebleed, the epistaxis. They didn't know before then. Multi-select. A child with hemophilia has fallen, his knee is swollen and painful. Treatment would include what? So remember, hemophilia is a lack of a factor that makes a child bleed. And you need to replace that factor or they're going to continue to bleed. So you're going to do that RICE, right? You're going to rest, ice, contain, and elevate for sure. You put exercise in the knee, you're going to create bleeding. You put hot packs, you're dilating the vessels and you're going to increase bleeding. So that's why you elevate cold packs. What is the priority nursing action for a suspected blood transfusion reaction? Anything that you think antibiotics, medicines, blood, you see in something that looks like a reaction, number one, stop it. And then worry about it later. That maybe it wasn't a reaction, but stop it. Let's prevent worse from happening. A child's admitted with neutropenia. What nursing action takes priority? Remember, neutropenia is a low white count. What are white blood cells used for? To fight infection. If you don't have white blood cells, you're apt to get infection. So, hand washing. Always number one, hand washing. Which symptom would a healthcare professional expect to see with a child with leukemia? It was like my girl next door. Today that girl is a PhD in psychology from the University of Miami. So she did okay after having leukemia as a teenager. Bruising, fatigue, bone pain, classic signs. Very good. Your child with ALL has had recent lab results with a platelet count of 10,000. What is you should do? Your nursing action. What do platelets do? What do you worry about? That's it. Well, platelets are all about bleeding. So that question was asking about the bleeding part of it. Okay. So, of course, we're going to wash our hands. We're going to have some sort of isolation depending on their levels. But It is bleeding precautions when you're talking platelets. A multi. A child is placed on bleeding precautions for ITP. What interventions would the nurse do? ITP, immune thrombocytopenia purpura. And remember, the P is always about platelets. IT platelets. B. No injections. You're going to be monitoring that CBC, looking to see is the IVIG or the anti-D, is it working? And then always looking for active bleeding, the gums, the urine, the stools. And then I said, we do treat with corticosteroids sometimes. Child with Wilms tumor, which action by a nursing student causes the faculty member to intervene. What are you doing in there? This is the one where you do not touch that abdomen when you know it's Wilms tumor because little pieces break off and it metastasizes. As I said, they don't even do a biopsy. They don't want to puncture it prior to surgery. They just do the radiation, chemo, both or one, and then they just take it all out. So leave that tumor alone. Cancer of the body's blood-forming tissues, including the bone marrow, is called what? And that's leukemia. Very good. A child with ALL has a fever of 100.5. What should they do? What are they taught to do with a fever? Acute lymphocytic leukemia. They have a fever. They need to tell their doctor or they need to go to the ER. But they need to minimum first talk to the doctor. They're going to need an antibiotic. Okay. But we're not just going to increase fluids, take Tylenol, because remember, these children have no white blood cells. They can't fight infection. So they need something to help them fight it. So they need to get medical attention and they're going to order an antibiotic or they're going to send them to the hospital for IV antibiotics. Child is having a bone marrow aspiration. What should you tell the child? Remember, you put it in, it goes, I'm telling you, it's a crunch. You'll never forget it. Whether it's done in the xiphoid process or in the hip bone, it's intense. So be honest, it's going to hurt a little, but we're going to do everything we can to make it as little as possible. Years ago, we didn't do anything. We just basically held them down. But today, we've learned so much more about decreasing the stress of these children and even adults. If I was an adult, I wouldn't want it if I had it once and it hurt like that. So again, making sure we decrease the pain, topical and then deep lidocaine before we do it. Most common clinical manifestation of a retinoblastoma. This is what the flash used to do years ago in cameras. I don't know if y'all remember that. Little things that stuck up and they used to turn and these flashes used to go off. And you always had these white eyes on these cameras. Today we're just so lucky. It's called cat's eye reflex. It's like looking out in the dark and seeing an animal and you seeing those white eyes. That's what it's called from cat's eye. Your child's been diagnosed with a retinoblastoma. What information is important? Well, there's probably been some little clues that this has been going on. So, was there any signs or symptoms that you've seen? Maybe a lot of rubbing of the eye, certain things that looking back, oh, that could have been a clue. Not infections per se, but those other things. The rubbing, one of them is that. A goal of surgery for a child with an osteosarcoma. Remember, osteobone, sarcoma cancer, usually it's the femoral bone, it's long bones. And we have to take the whole bone, not a piece of it, not just chip it off. We can't. But we'll take the lower leg and put it up. We call it salvaging the limb. And because it's now attached, that child now has something to put a prosthesis on. It's easier for movement, for ambulating later on. True or false? Immunizations cause autism. Absolutely not. The reason this happened and the reason why I put this in here because it still may be a misnomer. Many years ago, we had this physician put out a false research article that said that immunizations, which was your chickenpox, varicella, cause autism. Because when do we take and diagnose autism? Right about two. What's that immunization we get then? It was the varicella. So it's one of those things that they went back and they realized it was false. And I believe they took this physician's license away for putting that out. A child is complaining about those skin markings for radiation therapy. They should be told what? What are those skin markings for? Right? There are absolutely those guidelines. Some parents will take and have a ceremony and wash off those things, when they're done with radiation. So make it into an event. A multi. Nursing care of a patient with immune thrombocytopenia purpura. They do not need IV fluids. Sickle cell disease needs fluids to dilate the vessels. This is just a lack of platelets. So it's bleeding precautions. No IM injections, monitor CBC, and corticosteroids. IV fluids is sickle cell only. When distraction is used, it helps what? And we've talked about some big diseases and we've talked about a lot of different procedures that need to be done. And you have a child who doesn't feel well. So we know that when you do distraction, the kid sort of forgets that they hurt, and they're not thinking about that. And give them something that they can do that they'll enjoy, whether it's their iPad, watching a movie, coloring a picture, whatever it is. And let me tell you, it works well. What assessment question needs asked to a child with a possible rheumatic fever? It's last week's question. This is one, and we're going to see one in week 9, I believe, 8 or 9. There is also a GU condition. Strep infections need to be treated completely because it can cause rheumatic fever, and we're going to see one more disease as we go forward. Signs and symptoms of asthma. This was on your quiz today, and the answer was asthma. Not bronchiolitis or bronchitis. And the one thing about asthma that you can always know it's asthma, it's that expiratory wheezing. Because asthma, the bronchioles, the inside of the lungs get swollen, so air goes in easy. It gets stuck. And you have to force it out to get the air out in the end. When you talk about bronchiolitis, croup, it's the upper airway swollen. Air can't go in. That's inspiratory. That's the difference between the both. Multi. What symptoms should be reported to the healthcare provider for a child with sickle cell disease? So chest pressure, is it chest or is it sickle? And then headache, is it going into a stroke? Both of those are emergency. Sores that do not heal, not necessarily there. Swelling of hands, yeah, that's normal. But we're talking emergency things that are things that they would really need to be notified. Absolute contraindication for nasotracheal suctioning include which of the following? Another question from last week. You know I'll throw some in. So if we look at all of these diagnoses, they're all upper airway. We don't want to do anything to increase swelling. So croup, epiglottis, tonsillectomy, leave it alone, nothing in the mouth. Iron dextran is given via which route? And we give it for iron deficient anemia, sometimes. If not the liquid, which is, remember, through a straw and do it with orange juice because it helps absorb it better. And we're going to give it IMZ track. And the reason is iron dextran. Actually, it was the first injection I gave as a nursing student, and I was scared because I had to do a Z track, and it was a 40-year-old woman. So it wasn't like an older person who didn't know. You have to pull the skin back, give it, slowly inject it out and close it up. Lock and load, I call it. It burns if it gets on the skin and it also discolors. So that's why Z track. Pull the skin back, give it, and then it's like a lock and load so it doesn't ooze out. If a child was to receive their own bone marrow, this is called a blank transfusion. I think my tricks will tell you which one is which. And that's automatically mine is the best. And allogenic is all the other people. Very good. You listened. What cancer may present with painless, firm, enlarged cervical nodes? Painless, firm, enlarged cervical up here. And that's your Hodgkin's lymphoma. The one that's diffuse is your non, right? A multi. What teaching about sickle cell disease would you include? So we are going to give extra fluids, keep the vessels dilated. We want to keep warm so that when it's cold, those vessels don't constrict. Always pain medicine for symptoms so it doesn't get out of control. And fever, we need to get to medical care because they're immunosuppressed. Thalassemia major is treated primarily with this Cooley's anemia. And you do have some weird shaping that goes on with it also. This is when you have those rectangle cells and they burst. They have a very short life. And we know that the body only produces those cells. It is treated with blood transfusions. We're also going to be doing chelation therapy because of all that iron that's being out there. So, blood transfusions, and then we're going to do chelation therapy to get rid of the excess iron. A multi. What are opportunistic infections of HIV? And it's that candida, yeast, and then the pneumocystic pneumonia. Those are the two big ones. I mean, PCP pneumonia is severe respiratory and they could collapse, requiring intubation. Candida is usually treated with topical medicines if it's orally. Could be vaginally too in women. Multi. Treatment of osteosarcoma includes. So we either do amputation because sometimes we can't salvage the limb. The absolute goal is to salvage the limb, put the lower leg back up into the hip joint so we can put prosthesis, and we do give chemo. There is no stem cell transplant for this. You've got to get rid of that bone. You have to do surgical removal. A multi. Who are the best donors for bone marrow transplantations? If it's not you, your siblings are actually the second best one. Mom and grandma, really not as much because you're the combination of mom and dad. So siblings are the best after you. What is the most common opportunistic infection for children with HIV? And that's your PCP pneumonia, most common. We would think it's Candida, but no, book says pneumocystic. What would you consider to be neutropenia or a low neutrophil count in children? Remember, this is the one I told you to look at immune systems in children, especially those that are on chemo, but also other normal children because they can go into septic shock really quick. And with a fever, this child is dangerous. and it's at less than 500. It's usually over 1,000, 2,000. That's usually normal, but less than 500, there's no way that child can support themselves. We need to make it a priority, especially if they already have a fever. A primary characteristic of a brain tumor is what? So symptoms are becoming worse over time. As I said, those headaches should wake you up at night, and vomiting has nothing to do with eating. But if the headaches are getting more and more and vomiting is more and more, that's not related to eating and then waking them up, then we know something's really bad going on. The optimum treatment for osteosarcoma is what? So we're taking out that femur bone. What is the optimum? And that's trying to salvage the limb. We do not save a bone. The whole femur bone is taken out because anywhere in that bone now has cancer in it. So they take out the upper half of the leg and they take the bottom and put it up. Salvage the limb. Optimum. And last question. A child's receiving the induction of chemotherapy. What does that mean? So the induction is just intense. I'm telling you, the bunch of chemo, different types, hitting this cancer from all different ways, and the goal is remission. Those other 3 steps have to do with making sure we got all those little sneaky little cancer cells that are hidden to get rid of it and continue with remission. Very good, guys. Let's see how we did today. Turbo, number 3. Number 2, Miss Fig, good job. Number 1, oh, BB, my initials. Cool, I won. Bob and Miss Frey. All right, guys. Remember, this week you do have your reviews. Try to do as many as you can. I know you listen to them in all different places, which is fine. I know people in the car or at bed when they're going to sleep, whatever you have to do. Anybody who wants to meet with me prior to the exam, let me know. I can go over some concepts if you're having a struggle with them, okay? So I will see you next week. Remember to be here a little bit early so that we can set up and get started by about we start at 2:30, like 2:35. It's like I want to get started because we still have class afterwards and it's some heavy information. So try to be on time. Come in on your phones. Make sure they're all plugged in, ready to go, right? So thank you guys for another good class.
Thank you.
You're welcome.
Can we tell you now that we're going to go to the campus, or do you want to email?
It has to be from